Hola a todos, estoy con el doctor Moul. Fue el presentador de la charla de que es cáncer de próstata resistente a la castración, sea M0 o M1. Dr. Moul, this is an interview of you gave us in the other college about prostate cancer, resistant. We have four questions. The first one is the PET-CT is always do have after the CT negative and bone scan negative.
Well, thanks very much for inviting me to speak. We're here in Chicago at the American Urologic Association meeting, and we just did a course on advanced prostate cancer. And so when we have a patient with non-metastatic castrate-resistant prostate cancer, we now have the riches of having 3 oral agents that we can use. We could use enzalutamide, apalutamide, or darolutamide. And these drugs all improve metastasis-free and overall survival. The question comes up is, do you need to do a PET scan? You do not need to do a PET scan. You only should do a PET scan if it's going to change your management. So if you have a patient who is eligible for these oral agents, they're going to be eligible for these oral agents as long as they have negative traditional imaging. Now, if you have a specific indication where you think you might need to do a PET scan, that's reasonable, but you shouldn't just automatically order any testing unless it's going to change your patient management.
Okay, that's right. We are doing everything you will show us, and I made too in my practice. The other question is the patient that have a neurologic problem. The only prescription for this patient and cancer-resistant prostate cancer is darolutamide.
So yes. So again, as I mentioned, we have 3 FDA-approved agents for non-metastatic castrate-resistant prostate cancer: enzalutamide, apalutamide, or darolutamide. However, if the patient has a seizure disorder or epilepsy or something that would make him more susceptible to seizure or neurologic issues, then apalutamide and enzalutamide are not indicated. We're not supposed to use those in patients who have a seizure disorder. But darolutamide, since it does not cross the blood-brain barrier, would be permitted to be used in patients who have a neurological condition.
The only darolutamide in this case.
Only darolutamide in this case. That's correct, sir.
Okay. And the question is trial is who prescribed this molecular apalutamide, darolutamide, and enzalutamide in this case of patient for castration-resistant prostate cancer?
Well, I'm a urologist, and I'm old school. I've been in the field for a long time, and when I went through training, it was urologists who managed advanced prostate cancer. It is part of our urologic heritage to know how to use hormonal therapy or androgen deprivation therapy. And enzalutamide, apalutamide, and darolutamide are not difficult drugs to use. Now, you have to understand the side effects. You have to know the side effects and know what to look out for. However, it's not much different than the combined androgen blockade that most of us grew up with. We all used to use flutamide. We all used to use nilutamide or bicalutamide. These pills are, simply put, much more potent oral agents. And in my opinion, there's no reason that a urologist shouldn't or couldn't use these drugs, especially a urologic oncologist. I mean, if someone is a fellowship-trained urologic oncologist, yeah, I understand they want to do surgery. I understand maybe they're interested in robotic prostatectomy and et cetera. But look, we should know how to manage it. That's what sets us apart as fellowship-trained uro-oncologists.
Yeah, that's right. And so we are doing this practice and every day for our patient. We diagnosticate by the biopsy of prostate, by ultrasound. Next, we can do the treatment for the prostate cancer. If the CT is negative, the bone scan is negative, we can do a radical prostatectomy, or in cases, radiotherapy located. And the follow-up to the patient is monthly or each 3 months with the PSA. And this one, if rise in 3 occasions, we make another again everything, the imaging test, the CT, and the bone scan. And this, if it's negative, we have to change the treatment for the analog and the darolutamide, enzalutamide, or apalutamide.
Absolutely.
So appreciate this time for the doctor is needs moment for giving this interview. And the final question is the sequencing in the M1 castration resistant prostate cancer. If the patient, you start with enzalutamide or apalutamide, what's next if this patient progressed of enzalutamide or apalutamide?
So that's a great question. I mean, what we've learned is that these oral agents have been game changers. However, when you use an oral agent, whether it be enzalutamide, apalutamide, darolutamide, or abiraterone, your best benefit is going to be with that first oral agent. What we've learned, though, is it's the second oral agent, not so much. So, for example, if you've used, say, enzalutamide for 3 years and then the patient is progressing, probably not a good idea to go to a second oral agent. You're better off going to something with a different mechanism of action. That might be chemotherapy, that might be radium-223, that might be an immunotherapy, or it might be a PARP inhibitor. But simply just switching from one pill, from abiraterone to enzalutamide to apalutamide to darolutamide, just doesn't make any sense. Pick the one that you like, use it first, use it early, monitor the patient closely, but when the patient starts to progress, think about a different mechanism of action.
In a case, I'm from Ecuador. In Ecuador, we have just 3 molecules for M1 castration-resistant prostate cancer. Is enzalutamide, docetaxel, and abiraterone. And if my case, or the oncologist, if the M1 castration prostate cancer resistant, we have the starting with enzalutamide. Next step, docetaxel. If that patient made the BRCA test, if negative, it's go to docetaxel. But it's BRCA positive, is we have olaparib 2.
Correct.
Right? And so thank you, appreciate your moment, and for this, after this speech, very, very interesting. Say hi to Ecuador, and I hope you visit Ecuador sometime.
Thank you so much. I really appreciate the opportunity, and I hope you enjoy the rest of the AUA. Thanks so much.
Listo, esto ha sido la charla con el Dr. Moul. Nos veremos pronto en Ecuador.